hear you. Very nice.
Okay.
You. Let me, still, we're waiting for the people to join. There is three only on outside, so we're waiting for all. I will introduce you first, okay?
Okay. Yeah.
Then after that, we will start with some questions,
Okay.
and you can later on you can share your slides when you want to present. Yeah.
Yeah. If people want that, or we can just talk. I don't mind. It depends. I mean, if there's only three, we can just have a chat.
No, no, no. This is will be a lot, inshallah, joining.
Okay.
No, because the time
It's
became
probably
short.
not good for them. It's okay for me, but not great for them, maybe.
So we have also Abrahman. I will make him the co-host. How are you, Abrahman?
I'm good, Tarek. How are you?
I'm good. So I just made you as a co-host. Then you can admit people from outside, or you can manage the question. And I know that you have a lot of question also to Anne. So once we became 7:30, I will start, and this meeting will be recorded, and so
Okay,
a lot of
that's
people
fine.
will see the record also. So don't don't
Hmm.
worry about that.
Okay, don't worry.
Hmm. Okay, so Abrahman, I think you have a lot of questions, yeah?
Hopefully, it will be cleared by the meeting first.
Yeah.
I might not know the answer. We will see. We will see.
Yeah. So I will start with my questions. Later on, when we start, it is like what we face in our practical life, our real life. So it is just not like a very difficult question, and we people need to hear from you to help their judgment and assessment. Yeah.
Hmm.
So once we 7:30 exactly, I will start to admit the people, and also I prepare the introduction for you.
Okay.
Thank you actually for joining.
That's all right.
So, Abdurrahman, can you manage the admission for the people, or you want me to admit them first?
I've just admit few people. I don't know if it's working from my side.
Yeah, it's working. So still yes. No. Yeah. I think now we just take care now. All the people will come. Then you can admit. So hello everyone. It's my pleasure to present our brilliant speaker, Anne Raja. She worked for the NHS almost for 47 years. And let me start record first. Then yeah, already recorded started from since we started. Yeah, okay. And work for the NHS for almost 47 years, with 41 of those as a midwife. For the last 9 years, she has been the lead midwife for the infant feeding at the University Hospital of Leicester, which is NHS Trust, and has had a long term interest in supporting mothers and parents with feeding. And also, she had a diploma in health education and breastfeeding. Also, some of the important bit, which I have a question for it, which is she's a tongue tie, has trained as a tongue tie practitioner also. So, uh, welcome, Anne, and I need to confess that you actually replied to my invitation very quickly, and this may be one of the fastest webinar which I did. So
Okay.
thank you, Anne, for being among us, your audience from everywhere, and it will be, I expect it will be more and more once we started. Um, uh, as From my point of view, I start because really I planned this topic because what I face as a Tari, as a problem when I work as a registrar and receiving a lot of calls from the midwife that one of the baby is not feeding well, baby at risk of hypoglycemia, and they are not feeding. And this really, for me as a pediatrician, the decision of admitting the baby and separating the baby from mom, and also admitting a baby to a cot, which maybe he will not need it because many of them sometimes we admit them, then they feed by their own. So it's really challenging to go and assess and or because they are not feeding, admit. So, what is your perspective for such topic like infants who's just born and we receive a call from midwives that they are not feeding?
Okay, so it would depend on the circumstances, wouldn't it? So if the baby is a term baby, labor hasn't been particularly stressful, and they have a good birth weight, then the fact the baby's not feeding isn't too much of a problem. We can wait, we can see. If it's a late preterm baby that's going to be in transitional care, then they haven't got the fat stores, and so we need to be ensuring that babies are feeding within the hour after birth, usually, if we can, and then ensuring about every 2 to 3 hours that baby's feeding. If we manage breastfeeding, it never goes as well as if we just let it manage itself. But unfortunately, if you have a preterm baby, they often don't manage because they don't wake and they don't feed effectively. And so that's why we start putting plans in place. Once you start putting plans in place, it becomes more problematic because then you have to keep on making the plan. And if you're wanting to breastfeed, the best way for it to go is that babies go to the breast, they feed, they go to sleep, mothers put them down, they pick them up, they feed them again, they put them down. But if you've got a preterm baby or a baby who is struggling for many different reasons, then that's more problematic. So it's a tricky one, isn't it? Because when you're working on the ward, the majority of babies are going to get there. And certainly my guideline at the hospital we work at, I wouldn't be expecting to be worried and getting hold of a doctor until probably about 12 hours after the baby's born if they're not feeding. And in that time, I'd be expecting mothers to be helped to hand express. If they've got a term baby, probably only hand express and keep the baby in skin to skin, keep trying to encourage the baby to think about feeding. Anything you get, you would give. So any colostrum that you collect from hand expressing, you would give. If you've got a preterm baby, then you would also introduce the pump quite early because the baby's not going to feed effectively. It's not going to be stimulating the breast enough. It's going to be tiring very quickly. And so the mother won't be getting that stimulation to start to produce milk. So you would be introducing both hand expressing and pumping pretty quickly. In that case, you would do the skin to skin at birth. You would allow the baby to have a feed if it does, and then you would be expressing. Does that answer it, or does that not
Yeah,
quite?
yes, the question bring a lot of question also because you mentioned about they should wait about 12 hours before escalating, and
That's
actually
a term. That's a term
the
baby.
term baby, like, but if the
Yes.
term baby is a term baby but at risk of hypoglycemia, shall they wait?
All right. Now, if you're on the hyperglycemia pathway, that's a whole different ball game, and you don't wait. You do
Oh,
not wait.
wait,
No,
yeah.
no, no, no. So that's what I'm saying. It very much depends on your baby. So if you've got a baby at risk of hyperglycemia, then they're on the well, in this country, they're on the BAPAM pathway, and you're following through on what the advice is on that. And there's different flow charts, and according to different scenarios, you would do different things. So what you would hope is that the baby has a feed at birth, and then within usually the next 4 hours, you would hope the baby's going to wake up. But physiologically, the baby doesn't expect to have to wake up for 6 hours possibly. So that can get a bit of trouble, because the normal run-of-the-mill thing is that a baby would have their first feed, then they go to sleep for between 4 and 6 hours. But if you've got a baby at risk of hypoglycemia, you're probably starting to say, could you please wake up? Now, if it's also preterm, you're only going to give it 3 hours, aren't you? You're not going to be waiting, and you're then going to have to do your pre-feed BM, which could reassure you, because if the pre-feed, sorry, no, don't call them BMs anymore, do we? Blood glucose. If your blood glucose is okay and different, I won't actually give you a level because it's different in different places. But if you're, for where you're working, if the blood glucose is okay, you don't need to be panicking quite so much, do you? But if it's already low, then you're having to put interventions in. So again, it depends on what your scenario is and where you get to.
Yeah, so the intervention here will come again to a plan, and we need to stick to the plan.
Yes.
Yeah, so in the same topic, also babies at risk of hypoglycemia. So another scenario that they telling like mom had a little of milk, and definitely we know that is colostrum and very important. Then for me, because I'm always concerning about admission or no admission, so then I tell, okay, can we try formula? And this is because like we are breastfeeding, promoting breastfeeding all the time. Then when to come to this point, admission or no admission, shall I tell them to try formula now, or what I can do? So what is your advice in this?
So if you're wanting to protect the breastfeeding, then you need to be looking at, has she actually got any colostrum? Because some mothers can produce quite good quantities of colostrum. Also, can the baby breastfeed? Has anybody actually watched to see, is that baby transferring milk? If the baby's transferring milk, we know that in those first few hours, that the baby would normally expect to get between 5 and 7 mils of colostrum. And this actually can maintain blood glucose better than formula, because formula moves you. So it depends again on your baby. And this is why it's quite hard when we talk about these things, because if you've got a baby that's got a good fat store, but it is at risk of hypoglycemia because, say, the mother had diabetes, then the fat store's still there, and the baby can access the fat stores to a point, not as well as if they didn't have the issue of the risk of hypoglycemia, but they can still access the fat stores, and so they can use their ketone bodies. So their blood glucose may not be optimal, but they may be accessing their ketone bodies, so they may be doing fine. But if they have no fat stores, then their accessing ketone bodies isn't going to be as efficient, is it? We also know that if you give formula, then the baby doesn't access their ketone bodies as efficiently either. Because if you kind of think of when we're trying to help babies access their ketone bodies, you're kind of thinking like the keto diet. And on the keto diet, you're trying to keep carbs quite low, aren't you? So that you're using fat as your energy. And babies do this quite naturally if they're a well baby. And if you give them formula, is like giving them a carb, and then you're coming out of your ketosis, and then you're expecting more carbs. So you're expecting more sugar, but you may not have the quantity, and now the baby can't do the switch. So that's when it gets a bit tricky with the formula. And then also, what volume of formula? Because often I feel, and because there's no really good evidence of what level of formula we need to be giving. So if you look in one place, they'll say it's, so even in our BAPM guidelines, it says between 40 and 60 mils per kilogram. So it doesn't even give you an absolute number, does it? So it's a really tricky one. And I can see why there's questions. And I don't know that we can give definitive answers. I think it's something it's for each case to look at, and what's the mother's ability to breastfeed? What's the baby's ability to breastfeed? What is the amount of colostrum that she's making? How effective is that maintaining the blood glucose? Because if they've had that feed at birth and you've still got a blood glucose that's good, then you can assume, until you've got other symptoms, that this baby's doing okay. But if you're getting other symptoms, then you need to be on the case. And then, of course, we've got the buccal dextrose that you can give as an alternative, but that's a bit like your sugar shot, isn't it, as a diabetic, and then you need to have a carb to keep it going. So you must get a feed in. So if the baby's not breastfeeding and you can't get colostrum, you've got to use formula. That's where you end up. It's an inevitable.
But while you are talking, you explain something like always make me wonder when they told me the baby didn't feed like for a long time, and when we check the blood sugar, and we find the blood sugar normal. So now we highlighted the process of using ketones, and this maybe answer what like hidden question in myself: how they maintain the sugar and they didn't feed. So maybe this is ketosis was the answer for that. I remember that I attended one session with you while we are doing postnatal ward. You explaining to mom how to assess the quality of feeding and how to like if the baby like passing urine or passing stool or how many times, and this is give us like indirect answer for is they are feeding well or not. So what is what is your when you tackle this, what you're telling to the parent, because I really admire what you are telling at that time.
Okay. So I try to make it simple, and I think it's the Americans that probably came up with this, because I think many people make it a little bit too complicated. But in the first 24 hours, every baby we know needs to pass urine, and they need to have opened their bowels past meconium. So one and one. And then in the next 24 hours, they need to do 2 nappies, wet nappies, and another meconium. So each 24 hours, you go up the number of wet nappies until you reach 24 hours. And I say that because we start with a 0 and then we move. So it would be day 5. But if you start with a 1, then it would be day 6. Does that make sense? So it's six
Yeah, yeah,
24 hours.
yeah.
And also sometimes with these babies, you do need to look at the time they were born, because
Mm.
if they were born very near midnight, they will have had their 24 hours. But if their 24 hours is starting at 10 o'clock in the morning, you really need to be doing your 24 hours till there. So you need to have had 1 wet nappy in that 24 hours, and then you need to have had 2, 3, 4, 5, 6. And then with the stooling, they need to be doing at least 1, another 1, and then we need to be moving into 2. And then we should be looking at changing. The color will be starting to change. And round about day 4, 5, we should be getting a yellow stool, and thereon in they should be. And in this country, we're a little bit mean. We only need to have 2 yellow stools that are about the size of in this country of a £2 coin. So a significant amount of poo twice a day. I know that in America they often like them to have done 4 poos in a day. But we're happy with 2. But if a baby does not pass a stool in the first 4 weeks every single day, at least twice, then that is usually a good indication of underfeeding, and we need to feed more. Now, in the past, we used to say 7 days and it was okay. Now, a red flag, so like with your NEWT charts or your newborn charts, when you're looking, the first thing that you're looking to see that's going wrong is usually the resps. The resps go up before the temperature, before the pulse. The baby starts to breathe a little bit too fast, and adults do the same. In lack of feeding, it's the stool that goes first. So either it's not changing color, or there isn't enough. There's just a mere smear in the nappy, and there's not enough there. If the milk's going in, the poo and the wee's coming out.
Okay, that's very good. So another thing before escalating to the other topic, uh, uh, because I work a lot with neonates, and it was first time for me to see this checking the weight by like losing weight like 10, more than 10% because as a physician, we know that there is a physiological weight loss which can reach 10%. But here we check the weight on day 3 and day 5, and if it is because you face this problem while baby families won't go home, but we hold them because there is a weight loss on day 3, like maybe 8%, which is still, we don't have like actual number to say okay he's not feeding or feeding, because we know there is a physiological weight loss. So what you think about going with the weight, or going with weight nabbies, or how many poos? Like if they have weight loss but had a good nabbies, is any contradiction for this?
So sometimes it can be a bit strange, because sometimes you can have a reduction in the stool and the baby still doesn't appear to have had a big weight loss, but often it catches up. And if you aren't on it, you'll find that there's a bigger weight loss on the next weight. So it's not that they aren't losing weight, it's just not quite hit somehow. And it can be odd, that contradiction occasionally. But usually, if there's a lack of stool, you will see a bigger weight loss. Now, it's a difficult one. It's a difficult one as to what is a normal weight loss. So there's a few research papers out there that, and this is what most of our guideline for term babies is based on, is that a normal weight loss is between 5 and 7%, and 10% is an excessive weight loss. So that should trigger a review at a 10% loss. I think that's why at our hospital we have a 7% weight loss, just so that we are making sure this baby is moving in the right direction. One study showed that if a baby had more than a 7% weight loss, either term or preterm, I think I'm right in saying, that they were more likely to go on to struggle with feeding than if they had a below 7% weight loss, that their feeding pathway tended to be improved, rather than if they have those bigger weight losses, and their overall health seems to be impacted if they have those bigger weight losses. So we're trying not to even reach the 10%, aren't we? Unfortunately, all too frequently it does happen, because mothers believe that the babies are feeding well, and they they say, oh, the baby's being sick, so I stop feeding, and actually the baby's not quite feeding as well as they should, and then it's, when do you introduce a nasogastric tube? So there's lots of things, isn't there, that's tricky with feeding. Yeah.
Yeah. Yeah, so another also tricky thing, like primary gravida mom was their first experience, and we are as a physician, we most of the time we didn't assess the nipple, or if there is a cracks, or is this like really this need shield or don't need shield, or because even the nipple shield was new experience for me. I didn't use it, and like I practiced before coming to UK maybe more than 15 years, and I come here and said, okay, they are using nipple shield for the mothers that had a problem, or for nipples, cracked nipples. So how to tackle this? Because there is a big difference for mom who breastfeed before, and mom with a new experience. You don't know how even to hold the baby. So how to manage this?
Yes, so primogravidas are an interesting one, and if we can manage to get them antenatally and to talk to them about feeding, either in a session, a class, if you like, or through individual talking to women, or sometimes they do research themselves, but the evidence is that if a mother is prepared before she gives birth, then she does better when she does give birth. Even if she hasn't breastfed before, she's got some idea of what to expect. She knows that her baby's going to be awake at night, that their night feeds are important, that babies are very unsettled at night, and that's normal. This isn't something wrong with their baby. This is what their baby should be doing. And I think that's often a shock for a lot of new parents, isn't it? That they think that they feed, babies go to sleep, they feed, babies go to sleep, and actually they feed, the baby cries and cries, and they feed some more, and the baby's still crying. And what do I do now? Well, that's normal, just feed again. But it just feels all a bit too much, because somehow or other people just don't seem to be curious to find out before birth. So that is really, and if you're trying to be a baby-friendly accredited hospital, that is one of the things that you have to try to ensure that your parents are getting these antenatal conversations, that they are learning about the skin to skin and how important skin to skin is in making a start to breastfeeding. I think sometimes we think skin to skin is just a nice thing to do. If you want a baby to breastfeed, keep the baby with the mother, keep the baby in skin to skin, and then the baby's where dinner is, and then the baby can start to show feeding cues and get ready to go and feed. The mother's hormones will be working well, and her breasts will be starting to respond to the fact that her baby's there. Her baby's cry will help to trigger some of those letdowns, and this is why trying not to have them admitted to the neonatal unit is really important, because if we can keep them together, everything will start to work better, and mothers will start to learn how to handle their baby. They will start to recognize their baby's feeding cues, and they will feel more empowered that they're the one that's an expert in their baby, not staff. Nipple shields are, I have been quoted as saying they're the work of the devil, but they can be useful.
Okay, yeah.
So used wrong, they're just a total pain and they do nobody any good, neither mother nor baby. But used appropriately, they can be a very useful tool in, particularly with preterm babies who aren't able to sustain an attachment to the breast. Sometimes a nipple shield used in the short term can allow that baby to actually suckle at the breast. The trouble with the nipple shield is that it doesn't necessarily prevent damage to the nipple if it's not correctly fitted and used, and it can understimulate the breast, and so you may not get the milk supply that you want. And certainly if it's colostrum, babies can't get it out. So if you're sort of in the colostrum stage, I don't really, from my viewpoint, I wouldn't really recommend using a nipple shield. I'd say after 48 to 72 hours would be where you would look at using a nipple shield if it's needed.
Okay, thank you. There is a question here from Ramesh. She's telling if there is a 3-day-old baby having one wet nappy each day and is on breastfeeding, mom is not having enough supply. Do we apply this increment number of nappy with increment days?
So if on day 3 this baby's only doing one wet nappy, there's something awry, and that
Mm,
baby will be getting dehydrated, and definitely that they're not getting enough fluid.
mm,
So
mm.
you've got to decide how you're going to manage that. You need to look at the baby, and sometimes we assume that the reason for these things is feeding. And that would always be your first place to go, wouldn't it? But occasionally there might be something else up. So it's so if you've got that going on, it's always a set of obs, isn't it? See that the baby's healthy and well and everything's good. Checking that there's nothing kind of unexpected, like are the parents just missing that the baby's wet the nappy? And because although you want good wet nappies, if you've got a very small baby, a good wet nappy for that baby might barely touch the, if you've got these blue lines or all of these things, and it's knowing, is that nappy wet? If the baby did a passed a stool at the same time, has that hidden the fact that the baby's done a wee? So it's just making sure that really and truly this baby has only voided once every day, or did we miss something? Because if the baby's otherwise well, then it's optimizing feeding, it's getting more feeds in. If the baby isn't looking well, then you've got to decide, is breastfeeding going well enough that we can rely on breastfeeding? Do we need to introduce some other method of hydrating the baby? NG tube, if you've got a preterm, would that be a route to go down? And as I say, it's looking at the whole picture. If the baby's overly sleepy, if the mother's struggling to wake the baby to feed, these would all be signs that things aren't working as well as they should. So get her expressing, give the feed to the baby in a syringe if need be, or in a cup, or in a nasogastric tube, whichever thing you think in your area, because I'm very aware that every hospital has its own way of dealing with stuff, and every country as well does things
Yeah.
differently. So while I might tell you what we do here, doesn't necessarily mean that's what you do there. And I'd be very interested to hear what you do in other places as well. You know, I think this is a mutual sharing. It's not just me pontificating. So do
Yeah,
feel
it's
free.
definitely there is a practice everywhere is different. Even like I have a belief before that even if the baby had a weight loss in the first day or second day or 3 days, even I know that the baby with mom is more better. Like I remember because of some social condition. We discharged a baby home. He was IUGR, but he was 1.4 kilo. And because at that time the family was paying too much and they cannot afford payment on the in ICU, so I take the brave decision to discharge the baby home and with a follow up. And I was surprised when the baby came to my clinic within 4 days. He put almost 400 grams. So I was happy that I take the right decision, and because this is going with my belief. Like when the baby going home, definitely when mom going home, she's at rest. She everything available around her. She feeds the baby with whatever position she like. So this is was my belief. So what do you think about discharging
So
babies? Yeah.
I think it very much depends on the families because unfortunately I'm seeing too many babies bouncing back in again. And I think that's more distressing to be discharged and then be readmitted.
Mm.
And if they've been discharged, certainly from our perspective at our hospital, because of the neonatologist, their babies aren't admitted back into maternity care. They're admitted back onto the paediatric wards where
Yeah.
they're with children up to 16 and 17 years old. They've got all sorts of illnesses going on. And it's much more difficult for parents to get the support that they need to feed their baby, and inevitably they end up formula feeding. So I would prefer to see that the mother is confident and knows what she's doing. If she has a partner, that the partner is supportive and knows what they're doing. I think it's when you have, and I would guess that that family were very motivated to keep this baby well, and so they were on it. But because we don't, and this is a little bit of a problem in our service, isn't it? Because we don't pay for anything, people have a slightly different view of going in and out of hospital, possibly because
Mm.
we don't actually have to pay the cost of that. So
Mm.
if I said to a mother, if you go home now and baby doesn't feed well, you might need to be readmitted. If she might think, yikes, I can't afford that, so I'll make sure I don't get readmitted. Whereas in this country, it's kind of, well, okay, if I get readmitted, almost, and then they get admitted, and then they realise what a horror it was. But you know what I mean? It's not a financial burden, I think,
Mm.
and I think that can be a motivating factor. And and again, it depends on the baby because if it was just an IUGR baby, they're starving hungry. They usually are mature, they're just starving. And so they just want to feed, feed, feed. But if you've got a preterm baby of exactly the same weight, that one ain't going to do all right if you send it home too soon
Mm.
because they aren't going to feed, feed, feed. The parents are going to have to find other ways to wake and feed that baby.
Yes, one more point because unfortunately now I'm working inside the neonatal care, like intensive care only, and before I was having my clinic, even my private clinic, but now I lost the contact on follow-up of babies that previously I saw a lot of problem which is called colic, which
Yes,
the colic.
it doesn't exist apparently.
This is my beliefs, and when I explain to the parents that like inside the NICU, we see sometimes babies cried, but most of them because we arrange the time like if we feed every 3 hours or we feed every 2 hours, we feed on demand. So our babies is not crying like the baby who will go home. Like sometimes really families like they complain that my baby crying all the night and he suffers, all the family suffers. And like in my country, a lot of anti-colic medication, which I'm 100% sure that is useless. Like
No
some,
evidence it works. No.
yeah, 100% sure. This is useless. Some once the baby had colic, they write simethicone drops, which anti-flatulence. So some things that making nonsense for me and no benefit. And because when you explain to the parent and the baby having the same problem again, some countries they give like, and I unfortunately I heard it a lot. They okay, maybe your milk is not sufficient, and
Mm,
you have to add a formula now. And this is
no,
we come to
that
the
will add to the colic. That will make colic.
yeah, this will make more problem. What you observe if you are following up, is this is this a colic related to how much we like arrange our feeding, how going to
I don't know. I think that some babies just seem to, but I do think also it can be there's different reasons, isn't there, why babies get colicky? And one thing we also know is that there is a increase in crying that just happens gradually from about 2 weeks on, peaks at about 4 months, and then starts to go. And
yeah,
that very much follows the colic line. You know, the babies start getting colicky, it kind of peaks, and you think, I can't cope. And then around about 4 to 6, sorry, it peaks at 2 months. Around about 4 to 6 months, it starts to disappear. And then they think, oh, it's because I used the colic drops, or it's because I changed the formula, because it's just going to happen anyway. Babies cry more and then they cry less. And some babies cry a lot more, and some babies are just those sort of babies that don't bother. So, number one, it's what are the babies, you know, their character, what are they like, it's who they are. And we know that from, and we have a program here called icon, which I think they've had in America, which is to prevent shaken baby syndrome, and we tell parents about this kind of whale
yeah,
graph that crying will increase, it's normal. So there's that side of it. Then you've got an immature gut that is learning to digest a variety of different foods if you're breastfeeding. And some mothers will say there's a specific food they found that when they fed their baby was worse or had diarrhea or was more colicky. So they cut it out their diet. And another mother will say, I ate that all the way through and it made no difference. So again, it's one of those that if it's bothering your baby and you think it helps not to have a particular food, that's fine. Then we get onto the whole cow's milk protein allergy, which honestly is overdiagnosed, and most babies that are thought to have that don't have it. So,
mm,
and you can have blood in your stool and be colicky and still not have cow's milk protein allergy. And mothers are taking dairy out of their diet. And if it works and if it helps, and a lot of mothers will say anecdotally it works and it helps, then I'm not going to say no, but if you're going to go into any extremes, you should really get dietetic support because, and then if you are wanting to put your baby onto specialist formulas, obviously you need input from doctors and dietitians on that because um, you may be taking, particularly if you're going down the soya route, you may be actually causing as many problems as you hope to solve. Personally, I feel that colic is a thing. But I also wonder whether colic goes more with an oversupply of breast milk, so where a mother has a very full supply, so the baby is tending to get much more lactose-rich milk and takes longer to achieve the creamy part of the milk. I don't like using terms fore and hind milk because they confuse parents, but hopefully you as professionals understand what we mean by that because breast milk is not first this milk and then
yeah,
that milk. It's all just milk. It's just the way it's easier for the baby to take it. And also the fullness in the breast, the fuller the breast, the more lactose rich milk you'll have. And the more empty the breast, the more cream and fat you will have. And babies definitely who are having a lot of lactose rich feeds tend to be more colicky, tend to have frothy stools, may get green stools. So if a mother is struggling with an oversupply, she may well have a much more unsettled colicky baby as well. Then you
mhm.
can go into your whole reflux side of things, but maybe we don't want to add that to the mix at the moment. I don't know.
Thank you. I have a lot of questions, but let Abdurrahman ask his question first, and we come back to my questions. Go on, Abdurrahman.
Yeah, and thank you very much. And I have about two questions. So one question is like, for example, like you said, if a term baby well in themselves, like clinically, like for example, there is no causes to cause them to have feeding difficulties, as in like there is no sepsis, hypoglycemia, or jaundice, or any of those sort of things. And we waited for example, about 12 hours, like we try to do like skin to skin, and we checked for and transferable milks as well. And then part of the assessment, some people might say like, oh, and is it does my baby have like a tongue tie? And they, for example, one our clinician, for example, to check for tongue tie, is it one of the reasons why the baby will have difficulty feeding? And then I think we know from experience that doctors more tend to overdiagnose tongue tie. So, is there any way like we supposed to, for example, and assess for this, or do we usually, like in my experience, even because we don't have time to sit with the mother during the feeding time to assess? Usually, it's our experience midwives or and nursery nurse who do the feeding assessment, and they tell us like about their findings and stuff like that. And what do you think of assessment of tongue tie?
Okay, so in my experience, majority of doctors in this country don't even believe it exists or impacts or has any problems, and therefore we're not even allowed to consider tongue tie as an issue. I'm afraid, I know you're doing a thumbs up there, Tarek, but I'm afraid that is a bit of an old-fashioned notion, and you can find in old books from the 16th century etchings of how to divide a tongue tie. So it's been around for centuries, and people are aware of it, and they know that in some cases, uh, cutting the frenulum, doing a frenotomy is a necessary procedure. I think, however, it's become very fashionable, and it's not necessary in as many cases as it's being done. I would say privately in this country, there's quite a lot of frenotomies being carried out, but I wouldn't say there were quite as many being done on the NHS. Although I think the NHS does provide a tongue tie service, and it should, because in some instances a baby is just never really going to um, happily and successfully breastfeed. If you think of a tongue that is attached to the top of the gum by the tip of the tongue, and you think of that baby trying to open their mouth wide and scoop the breast because they need to bring their tongue out to scoop the breast, they're never going to do it, are they? They're going to struggle. And it's always, they might actually, if you've got a mother who's a mole tip, she may have successfully breastfed before and successfully get food into this baby. She might not even suffer damage to her nipples because she might be able to manage it so well. But in the long term, that baby's working really hard to get their feed, aren't they? Because that tongue is not working optimally. It's a bit like saying you have your breastfeed with your hand tied behind your back. You know, you play ball with only one hand. It's a tricky one. And my other thing is that when we're thinking about tongues, what do we want tongues to be able to do? We want tongues to be able to sit in the roof of the mouth because babies should be nose breathers. And in order to be a nose breather, your tongue should be sitting in the roof of your mouth, not in the floor of your mouth. If it's down in the floor of your mouth, your mouth is often open, and then you're often a mouth breather. And that's not ideal for babies. They should be breathing through their nose. And so where the tongue can position itself is quite important. So I don't think anybody should be assessing a tongue for a tongue tie that doesn't understand how a tongue functions, what you're expecting the function to be for feeding. So when I see a family, I will assess the function of the tongue. Can the tongue come over the lip? Can the tongue lift midway into the roof of the mouth? Can the tongue lateralize? And is that the whole tongue, or is it just the body of the tongue, or does the tip get held back? Can can the baby cup around, so if I was examining, it'd be around my finger or around the nipple, that should be a nice deep cup. And some of them are very flat. They can't get that cup because of the way they're tethered. Are they able to do a good sucking motion? Have they got a strong suck? How high is the palate? Because if the tongue's been sat in the floor of the mouth, it's not been up in the roof to broaden the palate and to shape the palate. The tongue, as a fetus, as they're growing, should be going up into the roof of the mouth to broaden the palate out. And then you've got to think where all of these things are attaching, and some of those muscles and various of the uh, my brain's lost the but there's bits that are going to be joining onto the hyoid bone, and there's other bits of the anatomy that are being restricted because of the restriction under the tongue, and it depends how much of a restriction is there, and it's very variable. I've seen some what would be described as very tongue-tied babies who feed beautifully, mum's happy, weight gain's great, she doesn't want to do anything. Well, I don't want to do anything. And then I've seen others where you think, goodness, I can barely see why this is a problem. And then you do a bit of an assessment and you think, okay, not too sure. And then you must always, always observe a feed when you're doing a tongue tie assessment. There's no point assessing a tongue without seeing a feed, because if the feed is optimal, we're not changing anything. But if the feed's a disaster, then an intervention may make a difference. So you always want whatever you're doing to make an improvement, not make it worse. And I would say in the time I've been doing this, and I don't actually practice as an actual tongue tie practitioner anymore. I did my training, and where I work, they said I couldn't be a tongue tie practitioner, so I left. I don't want to do private. I only ever want to support via the NHS, so I didn't decide to go down that route. But obviously I still assess, and I refer onwards rather than doing it myself. But if I had been allowed to under my contract with the hospital, I would have done it at the hospital, but they don't like it there. I also think it's right that we should not be doing a frenlotomy too soon, and that's another controversial, and these are just my views. It's very hard to get evidence around tongue tie. Any studies that have been done are necessarily problematic, and you can't blind the people to the fact that their baby's had a tongue tie division, for instance. So that makes it tricky, doesn't it? And so I don't think we should be doing it in the early days. I would say we can say to the parents, I can see an obvious frenulum. If you have somebody that is able to do you a proper assessment with a feed, then refer them on to them. And then it's a kind of a watch and see. And most of the evidence seems to suggest if by 10 days this feeding isn't going well, it probably needs something doing. It probably needs an intervention. But I would say in my time, I've probably seen about 3 or 4 babies that I would have said from the get-go, this child is probably not going to be able to feed successfully, and the sooner something's done, the better. And there are some views that if you're going to change a tongue, change it soon before the baby's learned to use it differently, so they learn to use it correctly once they've had the frenlotomy. And then I think you've got to think, I know it's only for feeding. Nice guidelines in this country say you only do a frenlotomy for a breastfeeding baby. It says they say it's not wrong to do it for formula feeding baby, a bottle feeding baby, but they don't recommend it. It's for the breastfeeding babies that they recommend, if needed, that we do it in a timely fashion. But I have seen some where the baby has then refused to breastfeed afterwards, but only about 2 or 3 probably in my career. The majority, it's kind of, thank goodness I can finally feed, and they get on, and those that aren't gaining weight start gaining weight. The mother feels much more comfortable. Her milk supply improves, because if the baby isn't sucking effectively, her milk supply is low. There's a lot of things that go with tongue tie issues. It's not just the baby. You've got to look at both mother and baby. How is it affecting her? How is she coping with this baby? How is she coping with the feeds? The baby may even be gaining weight and appearing to be doing well, but she might just be spending hour after hour after hour feeding because the baby's just taking so long with every feed. And you cut that tongue and the baby can feed in 20 minutes and she can get a break. So, you've got to look at the big picture. It's not just one thing on its own.
Okay, thank you. You have another question, Abrahman. You can start.
Oh yeah, and my other question was about a baby who would have like difficulty in feeding. Mom supply of breast milk is good, and those the ones, like for example, if we decided as a clinician that for any reason that we needed to do a feeding plan, and we tend to say like breastfeeding first, then top up if, for example, baby is not and having like a good session or enough session. But even though mom is able to produce enough milk, we sometimes advise to express breast milk. But then, and I think what's come after that is like, do we the top up, should it be like with a cup feeding for some hospitals, like advice for cup feed, and or like through bottles? And if the bottle was what's this been agreed on or the baby started on, and would that confuse the baby where, and it would be difficult for baby who's bottle feeding to breastfeed again? And how long would be, for example, for baby to be bottle feeding before it loses the skill to breastfeed or not to be interested in breastfeeding?
So again, we're little humans and we're all a bit different, aren't we? And some babies jump between bottles and breasts and it never seems to bother them at all. And others, the moment you introduce a bottle, they start to breast refuse. And you don't know which baby that's going to be. So I would suggest that you think very carefully about why it is that we need to be supplementing if the mother has a good supply. What is happening at the breast that's stopping that baby getting the supply? Now, is it because the baby's preterm? Okay, so that's a valid reason, and maybe therefore we do need to do something. If the baby's preterm and they're still in hospital, it might seem a bit more invasive, but is a nasogastric tube the best route to go down? If the baby isn't able to sustain a feed and get the nutrition they need, then are they actually mature enough to be doing a full feed anyway, whether it's a bottle or a breast? Because just because you're giving a bottle doesn't make it any less stressful or tiring or difficult for the baby. So we need to be looking at how that baby's actually coping with feeding, full stop, let alone how they're coping with breastfeeding. If the baby is actually I'd say it's very jaundiced baby. So again, can we give little and often, or is the baby under phototherapy? So we're needing to keep the baby under phototherapy. So we're having to reduce the amount of time out of the incubator and out of under the lights so that we can get the jaundice down. I'm actually trying to find out more about cups. I've been very happy using cups. I think they're a very useful way of doing it. Many cultures use cups regardless. I had a member of staff come from Brazil. She had never used a bottle in her entire midwifery career to date. And I think she'd been a midwife 10 years at that point. Until she came to work with me. And then she discovered that in the UK, we rather love bottles. She was used to using a supplementary nursing system, for instance, which is where you have a tube that goes to the nipple, and the baby takes the tube and the breast, and then there's extra milk that's going into the baby, so the baby gets milk more easily. I would quite like to introduce that into my hospital, but there's a few more things I need to get in place before we get there. The cup, I think, is a useful one, and it was designed for both preterm and term babies, but there seems to be some pushback at the minute from some neonatal units saying that they don't think we should be using it. I don't think I've got any evidence as to why we shouldn't be using it, but they're saying the babies are in danger of aspiration. Well, they're in danger of aspiration with a bottle too. And if really a fast letdown, possibly even with a breast, but babies tend to be able to pull away if it's going down the wrong way, if they're if they're on the breast, whereas with the bottle, we are in control and they may be choking and we haven't noticed. Um, because sometimes it can be quite subtle, can't it? But a cup, if it's used properly, it's very much to do with the person doing it. And if you're doing it properly, you are never putting milk into the baby's mouth. The baby is either sucking it or lapping it out of the cup. And so they should always be in control. They should always know when they've got milk there, and they should always know when they're going to swallow. And you're not moving the cup backwards and forwards. You are just keeping it there. You're not resting it too heavily because you don't want to be causing problems on their lower lip, but the cup just sits there. And a term baby tends to lap quite a lot, but also will learn to kind of suck, whereas preterm babies nearly always just lap and do it that way. And you should be able to see that little tongue coming out. And if you've ever watched kittens or dogs or anybody, you know the way they lap with their tongues, that's what babies do. And the theory is that that lapping motion with the tongue is similar to what a baby would do with breastfeeding, and this is why it tends to be more protective of breastfeeding. There was a study that showed that if babies were cup fed, they were more likely to go home breastfeeding than if they were bottle fed. It was statistically enough to show that, but it wasn't a huge difference. So that if you're on the side of bottles, you can argue for bottles, and if you're on the side of cups, you can argue for cups. And personally, I think there is a place for cups, but I think it's also parental wish as well, because not every parent wants to have to deal with cup feeding. If they're not going to be breastfeeding, they would rather just move to a bottle. But I think the main thing that we need to be looking at is, do we need to be supplementing at all? And if we do, how big is that supplement going to be? Because are we actually making the baby less keen on breastfeeding because they're too full, not just because you've used a different means of feeding? So if you're giving so I've seen some feeding plans where when people have worked it out, they've said breastfeed for 10 minutes and then give this top up, and the top up will be a full top up. So say the baby's total intake for a feed was 60 mils, they've said you've got to give 60 mils. Well, that means that at the next feed, the baby, particularly if it's formula, may not be particularly ready to feed because they might be still full up. Whereas often, if you can make it under the full feed, then they've got a chance to have a breastfeed and then top up. The other thing you can do is you can do a half top up before a feed if a baby's very sleepy, and then put them to the breast and get them to finish at the breast rather than start at the breast. It really depends what you're trying to achieve and why you're needing to do what you're doing. That there's not always this is the way we must do it. And I must say that limiting babies at the breast is problematic as well, because you might say to a mother, stop after 10 minutes, and the baby's only just got started and only just realized what it's doing, and it's just getting into a rhythm. And now you're saying we need to stop. So it's not just giving the instructions, it's keeping observing, seeing, talking to her, finding out what is actually happening. Because if you then say 10 minutes of the breast and then we're going to top you up with a full top up, what chance does she have to get back to full breastfeeding?
Okay, so always questions bring another question. So when yeah,
Always,
we talk about
always. I
yeah,
know.
yeah. When we talk about top up, like if mom had 15 minutes of breastfeeding and the plan was to give top up. When I said like full top up or half top up, because I don't know exactly how the baby take from his mother. And also it depend on the situation why you are topping up. Is because of initially there was a weight loss which we didn't accept, or the baby really is not latching. Then the second question will be how about latch score and tongue tie? If the latch score is good, this exclude tongue tie, or if there is a tongue tie, it will affect the latching score. So the
Both and neither. So the latching score will be affected by, and this is where, you were talking about nipples earlier on, and unfortunately we do have to talk about nipples, because the latch will be more problematic with the tongue tie if the baby's got no nipple to latch onto. With no tongue tie, most babies can still latch on a very flat nipple. You have to shape the breast to the baby's mouth. But for a baby with a tongue tie, there's no way to get that breast into the mouth because there's no tongue to scoop it in. So that's when people try to use nipple shields, and then if you've got no nipple there and you're putting a nipple shield on no nipple, you still got no nipple. Do you know what I mean? It's going to be tricky. So often babies, if they are given a chance, will figure it out, and mothers can help them. And even very inverted or very flat nipples, term baby often can feed successfully if you give them a chance. But if in those circumstances, often if you introduce a bottle teat to a mother who has very flat nipples, the baby is going to get very confused because now they're used to this sensation on their palate of a teat, and their mother doesn't have that. So again, this is where it's looking at each individual, and unfortunately not everybody knows what they're doing, do they? And you can't always have somebody there that can help, and so we do the best that we can, and that often does mean that we end up giving bottles.
So, how you say, like half top up or full top up?
Okay, so those so actually UNICEF baby friendly, sorry, I'm going to cough. Excuse me.
Bless you. Bless you.
Thank you. UNICEF Baby Friendly has a very nice chart which you can download on their UK website, certainly, which has I'm trying to think what it's called. It's a breastfeeding assessment for neonatal babies, I think it is, rather than, because if it's a term baby, you do use a different assessment form. And on that assessment form, it asks you various questions, and then it also says, if the baby had a good a feed that lasted this long and you saw this and that, then do a half top up. If they did this, then do a full top up. So it gives you A, B, C, D, I think goes down to F, and I couldn't tell you every single one, but it gives you a very good outline. And I think on our neonatal unit, we actually have them posted up in the nursery so the parents can look and they can see. So I will often say to a parent, because they've been trained to do their own nasogastric feeds, and I will support with the feed, and then we'll look at the chart and I'll say, I think your baby did this one, so I think we're doing a half top up, or I think actually your baby really just slept and did a few sucks, so I think we're doing a full top up. And we kind of have a little bit of a chat, and so that she begins to understand what we are looking for and what we're seeing as well. You know, did we see swallows when the baby was feeding, or did they just sit there and suck, suck, suck and never swallow? And so you're teaching the parents so that they can
Oh, yeah.
advocate as well.
That means it should be flexible, and it's not my
Mm,
decision. It is decision for the one who's observing feed. He said,
mm,
"Okay, let us go give full top up or half top up." So it is
mm.
it is not my plans, and him right, give full top up or half top up. It depends on the one who assessing and observing the baby. Yeah.
Yes, yeah. And
Mm.
it's very individual, as I say. Now, in the case of weight loss, that will be different because
Mm-hmm.
now we're trying to replace. So if you've got, say, a 12% weight loss, you're not going to say, oh, everything was working fine, because obviously it wasn't. You're going to have to find out why. So was it because mum's supply isn't there? Did she have retained products? Did she have a big blood loss? Now, for some mothers, 400 mils is enough to reduce the supply. And then I've had a mother with a 3 litre loss who didn't have a baby, who had a baby who didn't lose any weight at all. So, you know, it can be variable. So it's looking what's gone on, why is the weight loss? Now, if the weight loss is because mum didn't understand how to get her baby attached to the breast adequately, or because she had a cesarean section, so her milk's come in a little bit later, maybe we've corrected it and we can just feed, and we can use breast compression so we can squeeze the breast to help the milk come a little quicker while the baby's feeding. So we may not need to do a top up in that case. But if we've seen that the feed is effective, everything's working, but the baby still lost weight, you're going to need to do a supplement. And then you've got to decide, is it a half or a full supplement? And if you can see the baby's feeding and getting milk, then it's more likely to be a half supplement. If you can see that mum's supply just hasn't come in for some reason, then you're more likely to do the breastfeed, but you're going to need to do a full top up. So again, it's looking at the whys behind things, isn't it?
Okay, so you every time you mention something,
I just cause more problems, do I? Okay.
You remind me with something else. So I just you remind me when the mom had like a significant blood loss, and this we know that this affect her supply even after like the one mom was massive postpartum hemorrhage. Definitely, her breast milk supply will be affected. Also, I remember now that which is not making sense for me. The mom with very high PMI, like body mass index, like huge mom, also they at risk of, although it will not make sense, but they at risk of their milk supply will not be.
So it makes absolute sense because they are in a metabolic syndrome, aren't they? So if they are very overweight, then
Mm,
their body is having to work very hard and their hormones, if you like, are being spread too thin. If that's the easiest way to put it to you, their body was designed to provide hormones for a much smaller body, and now you've got this much bigger body. So you've got this body that's working really hard, and so the prolactin maybe just isn't able to kick in and get things going. They're often more likely to have other metabolic things going on, like they might have gestational diabetes, which we also know reduces milk supply.
the
So
polycystic ovary also syndrome.
but
Yeah.
absolutely, that can be high or low, interestingly. They can
Mm,
go either way with that, and it's called something new now, isn't it? But
mm,
anyway, that one, low thyroid function, or even interestingly, hyperthyroidism, because then they're on medication that might actually still be making, if things aren't working optimally, they still might be causing problems. So it's an interesting one. We know that for some people, not everybody, that even taking certain antidepressants can affect supply. So, but it's very individual again with each person. But also the other problem with the large BMI is the baby was expecting to find the mother's breasts, but they were expecting to find the mother's breasts at about a 20 odd BMI, not at a 40 odd BMI. So now they've got to take a mouthful of breast tissue that was a whole lot more than they expected. Does that make sense? So
yeah,
then
yeah.
if you're tongue-tied as well, you're really, and these again might be ones where nipple shields help because it just helps bring everything down to a more manageable
Mm.
mouthful, if you like.
Okay, thank you. That's a point for our colleague to consider when they reviewing a baby. Like, just give a look to mom size, like if like the small
Oh
mom.
yeah, and we
Yeah.
know that there's a few issues with having a raised BMI. Is that one, we know that your milk supply might be affected. Two, um, mothers, they've done a research study and they found that people are less likely to want to support a mother with breastfeeding if she's got a high BMI because it is more difficult.
Oh,
You have breasts that are reaching, there's no gap between the abdomen and the breast, and where does the baby go? If you're going to do the traditional cradle, the baby often is almost upside down. Um,
mm,
or
mm,
if you're going to not move the breast and you move the baby to the breast, often the baby's almost halfway down the mother's thigh. It really does
yeah.
depend on,
Well,
yeah, you can
yeah.
get some very odd things that you're
Mm,
trying to. And so what I'm doing is I'm looking and I'm thinking, what position is she going to be able to do that actually allows this baby to feed and the
mm,
baby can breathe and the baby and she can see what's happening, and we can actually successfully do this, because I was doing this with a mother recently, and we were using the rugby ball, but her breast was so big and heavy, it was laying really heavily on the baby's chest, and I was worried whether the baby could breathe. Not, but his nose was clear, but the weight of the breast on this baby. And
mm,
I'm saying, oh, could we just try moving? And if we moved in any other position, the baby couldn't attach. And so, and I'm saying, I think you almost need to hold your breast off your baby so your baby can feed. So that means that she was really tied up. I think as the baby got older and bigger, it would work fine. But and then you kind of think, well, what am I doing wrong? I'm not doing anything wrong. Unfortunately, her body wasn't designed to be that big, and we're now trying to manage what we've got, aren't we?
Okay, so thank you. Another like thing came to my mind about when you mentioned also like GDM mom or infant of diabetic mom, also they have like a struggle with milk supply, same like the mom with very high PMI or mom with hormonal disturbances, whatever, or under medication. So now, when we talk to this mom, and I know that when we, a lot of them, then they feel stress and they feel, okay, I need to feed the baby, especially when we said, okay, there is a lot of weight percent loss, and now we go and talk them, and especially also I noticed this one when my colleague mentioned about when baby had jaundice, and they say relate this jaundice to the amount of feeding, and they said maybe had jaundice now because is not sufficient milk, then this stress and this hormonal stress make a more suppression for the breast milk. So
It
how?
does.
Ah, yeah. So yeah, this is that's
No,
what.
cortisol, we know that cortisol and adrenaline suppresses oxytocin. So you are, and any mother that's stressed, she is going to find it hard to let her milk down. So yeah.
So that's how we balance. Like when I talk or approach this mom, what is the best way to approach? I need to alert her about the importance of feeding now, because if he's not feeding, you're going to stay more in the hospital. And if he start to feed, and you how to encourage her in a way, not make her stress. What is your best approach?
So it again, it's always individual to the mother, isn't it? But if she has got some of these conditions, she may already be aware that it could affect her supply. I think for me, just to throw another spanner in the works, I'm seeing more and more breast hyperplasia, and my sister is a consultant pediatrician, and she said to me, because I was talking to her about it, and she said to me, "Oh, I was told it was a vanishingly unusual thing to get was breast hyperplasia." I said, "I'm probably seeing at least one a month at the moment. Yeah, I'm seeing a lot, and so I don't know what's happening at puberty. I don't know what's happening, but nobody's really investigating these kind of things. So we've, on the one hand, we've got things that may be like the diabetes if it's well controlled, the BMI if you are on the case with expressing, you may get your milk supply. Hyperplasia is a really interesting one because actually sometimes they do really well and sometimes we're just getting nowhere fast. And it's also quite hard to diagnose because when you look at it, sometimes you think, oh, that one's not going to do very well, and they actually manage quite well. So again, that's the one I find hard to say because if I notice that a mother seems to have hyperplasia and I say, I just need to have a little chat with you about your breast development and whether or not, you know, you notice that you had an increase in your breast size when you were pregnant? No, my cup size didn't change at all. It's exactly the same. I noticed that one breast is slightly smaller than the other. Has it, do you ever recall it ever being different? Has anything changed? No, it's always been like that. Um, and then it's kind of, well, we do know that when you've got these kind of conditions, sometimes you don't make as much milk. So what we need to do is help support you with your supply. And your baby's also jaundice, so we need to be looking at how we can get as much milk as we can. So, and it's just gentle conversations, isn't it? They need to know the truth, but they don't want to be told, you've got no milk, your baby's going to get jaundice and you're going to stay in hospital for days on end. It's kind of, how we're going to make your milk supply, how are we going to manage this, what would you like to do? um, have you actually thought about this? Do you know that in order to clear the jaundice, your baby needs the protein in milk, and it does need to be milk, and breast milk's the best one for it. So if we can really help you get your supply going, even if the baby's not feeding at the breast, if we can make as much of your milk as we can get, that would be great. And any milk that we can't, we can we can use formula to help us along. It's kind of, looking at these things, isn't it? I don't know. When I've got the person in front of me, I'd probably say something slightly different. Do you know what I mean? But it's being gentle, but it's being truthful.
Mm,
We can't say, "Oh, you'll be fine. It'll all be good," because and then it's not, and then that's even worse, isn't it? And
yeah.
then I do have, "Oh, I've got to watch out for my mental health," and, "Oh, it's also stressful," and it's acknowledging, yeah, it is really stressful, and yeah, absolutely, you've got to look after your mental health. What is it that you would like to do? I'm just telling you that this is what we need to do. What would you like to do?
I think I cannot stop talking about this topic, but like a lot of question can arise, and I hope that the audience will be more. But anyhow, but one of the things that we came to my mind now about your experience about is the presence of breast pump in the like postnatal ward, and is really helpful to offer the breast pump for this mother, or it is like because the culture is different.
Okay, so on the whole, if your feeding's going well, you've got a term baby, don't pump. There's no reason to, no need, don't do it. You'll get an oversupply, it'll all go a little bit wrong for you, and it'll just be hard worked, and there's no need. It's an unnecessary thing. If you are wanting to introduce a bottle at some point, and why would you want to if breastfeeding is going well, but somehow or other men and partners feel like they've been left out unless they can feed the baby, which makes life for the mother a whole lot more difficult. If you actually think about this support where, oh, I'll give a bottle. If you want breastfeeding to be working and breastfeeding is going well, and now suddenly you've got to start pumping and you've got to start providing a bottle for somebody who's randomly going to sometimes feed and sometimes not, why? Why do that? But if you need to have a bottle because you are going back to work, or you are needing to go for appointments and can't take the baby, whatever it is, then we would usually suggest, if everything's good, you don't start pumping till about 6 weeks so that you don't get an oversupply.
Mm.
If you've got a preterm baby and they've disappeared off down to the neonatal unit, we would suggest you start hand expressing and pumping within 2 to 3 hours of birth, because you're likely to get a better long-term supply if you start pumping straight away. And certainly if you leave it 6 hours, some studies show that you're less likely to come up to the volume you need to get to. If you're a preterm mum and you've had a 25-week baby, you need to be hitting a volume of around 700 mils by 2 weeks.
Mm.
If you are a term baby and you're feeding at your mother's breast, you will not be trying to get there. But if you are, you will be getting there, but you will get to about the 700, but it might take you a wee bit longer. But what we know is that in order to have enough milk to sustain into the future, you need to be hitting about 700 by about 2 weeks. So you need to be hitting around about the 4 to 500 at about 1 week, which is a significant amount, isn't it? And so they need to be really helped and supported, and having the pump available. They need to be having the pump flange fittings. Now we're very much into getting the correct fit. It's a lot smaller than we used to think. The average size, most people are telling me, is between 15 and 17 mils, and yet we used to use 26 as standard. So it's getting, and if we can get these things right, it makes more milk, and the mother feels more comfortable as well. So this is why, although the first week's important with feeding, if you've got a preterm baby, the first fortnight's important, because we need to be getting to these volumes. And so pumps are a huge asset if you've got a baby that's not feeding at the breast. If you've got a baby that's feeding well, you don't really need it. You can go through your whole breastfeeding journey and never pump at all. It's just more if it's a replacement baby. If you just think of it as the baby didn't feed, therefore I need to use the pump.
Thank you. I didn't think that anyone have questions in the chat, so let me ask you some very quick question. You can say either choice A or choice B, and this
Okay.
no, yeah, like just it just came from the topic now. Like
Okay.
I told you like colic and medication. What do you think?
No,
Nothing. Cup or bottle?
I'd prefer cup.
Yes. Checking weight checks or weight nappies and booze.
All of it.
All of it. Again, latch score, weight nappies and booze.
Um, Wet nappies and poos, I think, is strong, but if you really want to understand feeding, latch score as well.
Okay, so once you have a difficult mom, like you have with hormonal changes, with very high BMI, with maybe also she's GDM or she's diabetic itself. What
Let's
is
just throw everything at it.
yeah, what's
Yeah,
the best advice for the medical team? Because you mentioned one of the things that you mentioned during your talk that you said we should prepare this mom. And are we preparing this mom that when they deliver either primary or multi gravida, when they have a baby, are we preparing them right in the right way that we expecting baby and we need to encourage feeding? And also because I read about what is called milk harvesting and which having some benefits and some drawbacks, especially in preterm babies. So where we are from milk harvesting and where we are from sitting with mom antenatally before delivery to prepare them for food.
Okay, so diabetic mothers, particularly in our trust, are very fortunate because we have a very good diabetes team of midwives, and they will see them and talk to them, and they will have explained to them that actually their baby is at risk of hypoglycemia once they're born, that they will need to be having blood glucose testings to ensure that feeding's going well. And every mother who is going through that should be given information both written and verbally. So if as we're introducing the antenatal colostrum collecting, we're hoping to start offering that at the 36-week clinic. So because that's when our trust will start antenatal colostrum collecting. They did a study in Australia called the DIME study, and they had mothers collecting colostrum from 36 weeks, and none of them went into labour. So that's why we consider it safe. There's a lot of mothers who breastfeed their baby while they're pregnant, and that doesn't tend to be a good way of getting people into labour. If you're going to have a preterm labour and you're doing stuff, then don't do this because yeah, but you're already, your body's in a different place. But if everything's okay, then collecting colostrum can be beneficial. So then you collect the colostrum and you freeze it and you bring it in with you so that when you have your baby, if for some reason you aren't able to feed your baby optimally, so within that first hour, or for some reason you couldn't get any colostrum at that moment because you had a GA and you're fast asleep still, somebody's still got those syringes there and we can give colostrum instead of formula. So we can ensure that baby gets that early feed, and 5 mils, if she's got 5 mils, is as much as that baby would expect to receive. So you've given them their first feed, it's all good. We can wait for the second feed when hopefully mum's awake, and then she can start to either harvest more colostrum or feed. Fresh is always best because putting colostrum in the freezer destroys various things, notably the oligosaccharides, which is one of the benefits of lining the gut and stopping various problems with the gut. So that one is not as effective if it's been frozen. So
This is new information for me. Thank
oh,
you.
right. So fresh is always best. So so the frozen colostrum is always your backup. It's never your first thing. Breast milk is also harmed by freezing. It's always best to use fresh if you can. So the the plan would always be to give mothers information, and baby friendly, although I'm afraid we don't always get it right in our trust yet, requires that mothers are given four talks antenatally. One is getting to know their baby while they're pregnant, so they know the movement, they're talking to their baby, they're connecting with their baby. This has been shown to make mothers more responsive to their babies when they're born. It also gives the baby a much less stressful environment, so brains grow better and things like that. So we're bringing back down the stress hormones because we're increasing the oxytocin as she's talking to her baby, and hopefully her partner is too. We need to talk to them about skin to skin, the importance of skin to skin, doing the first feed in skin to skin, not stopping skin to skin until the first feed's taken place. So that's not within an hour, that's as staying skin to skin until the feed has happened. Sorry, you wanted to interrupt?
Because skin this making a problem for me. Like when mom is hypothermic and mom temperature is 36, and they put the baby who was temperature nice to hypothermic mom, then they call us back that the temperature of the baby
Isn't
is
it interesting that mothers are getting hypothermic? Why are mothers hypothermic?
yeah. Maybe it's because environmental or because they are.
And I've not seen any research that says putting a baby on a mother with a temperature of 36 reduces the baby's temperature. It's not what the research tells us. So I'm finding it interesting. I think we should start collecting data on every baby that's hypothermic because the mother was hypothermic. Because I need to go back to baby friendly and say, what am I going to do in this circumstance? This mother has got a temperature of 35.6 or 36, and we now want to put this baby in skin to skin. Is the baby going to be warming the mother, or is the mother going to be cooling the baby? Which
I
which is it going to be?
Mom is going to call the baby.
Well, if the baby's nice and warm, she's going to say, "Hey, mum, let's warm you up." But
Okay, that's good.
the evidence is that the babies are meant to be warmed by being in skin to skin by a degree up or a degree down if they're too hot. So the mother's body is meant to be thermoregulating her baby. So I'm finding it difficult to understand why we're seeing these hypothermic babies. Is there something else happening as well as the mum being cold? Because why is the mother cold? Is the room cold?
Mm.
Is the and, when was the baby nice and warm? At what point was the baby nice and warm? Was it because you had them on the resuscitator and under a radiant heat? Or was it because they've just been delivered? Because how fast is a baby going cold on the mum? I don't know. I need to know more on that one, but it's an interesting one, is it? Anyway, skin to skin, for all that, is meant to be really good, and
Yeah.
I'm sticking with it. It is. And then, so they need a conversation about skin to skin, and then we have a conversation about how to get off to a good start. So it's things like not being separated from your baby, keeping your baby close, watching for feeding cues, understanding that picking your baby up and feeding as often as you want to isn't going to harm your baby. It's good for your baby. You can't overfeed a breastfed baby as long as you're feeding at the breast, because a baby just won't take more than they want. And then this whole idea of being responsive as a parent, that you're responding to your need to hold your baby, to feed your baby, you're responding to your baby's need to be fed. So we talk about responsive feeding, not demand feeding, because demand sounds rather brutal and I want it now, whereas it's more about hey, I'm quite hungry, or hey, I'm quite full, could I feed you? And that sort of reciprocal relationship is important, and those are the conversations we're supposed to have with every mother while she's pregnant. But
Mhm.
not every mother gets that for various reasons,
Mhm.
and I think that is a problem, and that's something we're still working on where we are. I don't know what other people are up to.
Yeah, that's good. If we have a plan and we have the perspective to implement this and to talk to them more before delivery, I think one day it will happen.
Well, it's on about about nearly 80% of mothers are getting the conversation, but you can guarantee it was always the one that you wanted to have it that didn't get it. you know? And then definitely if you've got a mother in preterm labor and you guys go and you need to talk to them and talk to them perhaps about collecting their colostrum before the delivery, because if they collect that zero point 0.2 before the baby's born, and then the baby goes off down to the neonatal unit, you can get that buccal colostrum in. So that little 24-weeker gets its buccal colostrum quite quickly. Whereas if we're waiting till after the delivery and mum's tired and everything's a disaster and she's weepy, and now, by the way, could you just express some colostrum for us? She will often if you put it to her right, but just doing it beforehand, if she's got some moments, it's sometimes everything's going very quickly, isn't it? But and also the value of it, how valuable it is. And a lot of mums in our trust, certainly, who weren't intending to breastfeed, if they have a preterm baby, give it a good go, don't they? They try to give us the colostrum. They try to
Mm.
express the breast milk. They are on board with what we're telling them.
Thank you too much. I'm very appreciating your talk, like in almost 1.5 hours now, and you are talking. So I think I feel, I, I
We better stop, otherwise people will get bored.
Yes, I will never get bored, but every like beautiful thing always come to an end. Every beautiful talk at the end, we have to finish it. So thank you so much for accepting this invitation. As I was willing more people can attend, but this also reflects that some of the people, they concentrate on the clinical, like intensive care problems, but every like breastfeeding is one of the best things that you should know about it and tackle the problem. Thank you. I think we'll have another invitation for you to talk, because my concern was, I don't want to admit a baby who is can be managed in postnatal ward, and we can support the mom for breastfeeding. But maybe we'll have talk about when the baby go home and what we can do exactly after that. Because like we used to like 2 years for breastfeeding. Like we
Oh
used,
yes,
yeah,
2 years is what we recommend, and worldwide 4 years.
yeah.
They
Whoa,
offer,
4 years.
yeah. Yeah,
Oh,
so the normal, so if you look at the statistics, the average time a baby will self-wean is around about 4 if they're allowed to choose.
oh. So we always like our babies 2 years and stop.
No, breast milk keeps on being good, keeps on being good, and particularly if the baby's unwell, because you're providing that immunity, aren't you?
Yeah, yeah. Thank you so much. And
That's okay.
I really I cannot express my gratitude to you for
No,
accepting.
that's fine. It's been a pleasure.
And I didn't see any question on the chat, so we can stop it now and see you
Okay.
in next time.
Okay. Thank
Thank
you
you.
so much.
Thank you
Bye.
very much,
Thank you.
Anne
Thank
and
you,
Tariq.
Abdullah.
Yeah, thank you.
Thank you so
Thank
much.
you.
Bye
Thank
bye.
you.
Thank
Bye.
you.